Inilabas na po ng IATF kagabi ang inaabangang para sa pilot implementation ng alert level system for COVID-19 response sa National Capital Region. Dito magfo-focus po ang pamahalaan sa granular lockdowns na kadepende ng tao at mga magbubukas na establisimento sa alert level system ng DOH. Para ipaliwanag yan ng husto, narito po si Yusek Maria Rosario Vergere, ang tagapagsalita po ng Department of Health.
Good morning, everyone. Today, I will be presenting a briefer on the alert level system that will be used in the pilot implementation of the proposed community quarantine policy shift in the National Capital Region. First, let me provide a brief situationer. Confirmed cases show a steep increase and has exceeded the 7-day moving average. Our epidemic curve shows that the latest peak at the 4th week of August has surpassed the peak seen last April of 2021. Cases from September 6 to 12 recorded 20,959 cases per day, an increase of 2,675 or 15% cases per day compared to the previous week of 18,284 cases. The National Capital Region contributed 28%, Region 4A 22%, and Region 3 at 11% to new cases in September. Nationally, we remain to be at high-risk case classification with a positive 2-week growth rate at 27% and a high-risk average daily attack rate which increased to 17.81 cases for every 100,000 individuals. 12 regions were also classified as high-risk. A lower positive 2-week growth rate was seen nationally and in 8 regions: National Capital Region, Region 4A, CAR, Regions 2, 3, 10, Caraga, and Region 12. The total bed and ICU utilization rate at high risk nationally and for 7 regions, which are CAR, Region 4A, Region 2, 3, 11, 10, and Caraga. The NCR maintains a positive 2-week growth rate and a high-risk average daily attack rate and is currently at high-risk case classification. The ADAR increased from 29.69 in the previous week to 39 per 100,000 population in the recent week. Total bed utilization was at upper limit of moderate risk and ICU utilization is at high risk. We would also like to show the analysis we did for our mortality, healthcare utilization, and detect to isolate data. We looked at case fatality per region and we saw that nationally, the case fatality rate was lower this year at 1.49% versus that from last year at 2.47%. The National Capital Region had the highest cases and deaths in 2021, but its case fatality rate was the lowest among all of the regions at 0.94%. It also had the highest full vaccination coverage at almost 60%. We computed the case fatality rate per month or the proportion of deaths among cases who were positive for this month. We noted that the highest case fatality rate was in March to April of 2020 at 10 to 19%. This decreased to around 2% by August of 2020 and further decreased to less than 2% by February of 2021. August of 2021 had the lowest monthly case fatality rate at 1.04%, but this should be interpreted with caution since there are delays in reporting of deaths. Comparing August 20 to September 2021, the number of total COVID-19 beds increased from 13,000 to 40,000. That is 210% higher. And ICU beds from 1,247 to 4,209 or 223% higher. While utilization rates were highest this August to September of 2021, had we not increased our beds, utilization rates for August to September could have reached critical risk, given that our ADAR and ICU admissions increased to almost twice compared to April of 2021. Case detection to isolation time seemed to improve from last year. However, there was no significant improvement in this interval, which was seen across 2021. Since March of 2021, detection to isolation have remained within 6 to 7 days. In the National Capital Region, the trend mirrors that of the national level. However, unlike the national healthcare utilization rates, the ICU utilization were lower for August and September of 2021 versus April of 2021, despite a higher ADAR and a twofold increase in the ICU admissions as total beds increased to 10,401 and ICU beds to 1,044 beds. Detection to isolation interval in the region also improved in 2021, with only little improvement through the months as interval remains within 6 to 8 days since December of 2020. Let us now look at our healthcare worker data. Case fatality rate is lower in healthcare workers than the general population and has remained below 1% since April of 2020. Looking at the national trends, while the peak in cases in March to April 2021 saw an accompanying increase in the number of cases and deaths among our healthcare workers, the number of healthcare workers cases and deaths were lower in April of 2021 and August of 2021 versus July to August of 2020. The reduction in healthcare worker cases and deaths were more apparent in the National Capital Region, with only 5 deaths reported in 2021. No death has been reported since June of 2021 for the National Capital Region. Note that the vaccine coverage for healthcare workers is 96% nationally and 94.7% in the National Capital Region. While we can see that there are more healthcare worker infections and cases in the past weeks, their case fatality rate remains to be low, most likely due to the high vaccination coverage and the protection of vaccines against severe disease and deaths. Our next analysis is among our elderly population. The case fatality rate among our older population was highest in March of 2020 at 31.4% nationally and 30.38% for the National Capital Region. It started to decrease to less than 10% since February this year. Even during the peak in cases last April of 2021, the monthly case fatality rate was only at 6.82%. Cases and deaths among senior citizens increased in 2021 versus 2020, both in the national and in the NCR data. But looking at the August 2020 peak, we had 8,838 elderly cases and 940 deaths. Comparing this to the April of 2021 peak, where elderly cases reached 18,231 with 971 deaths, which is only slightly higher than the deaths in August of 2020. Note that the vaccination coverage for elderlies is 50% nationally and 81.49% for the National Capital Region. Now let us look at the rationale for this policy shift and the use of our alert level system. This shift in our community quarantine policy was deemed necessary due to the following reasons. First, as we can see in the graph shown, we were more mobile during the latest ECQ last month than during the ECQ in April of 2021, as more essential activities and workers were allowed. Second, it was found that 80% of our new cases only came from a small proportion of our barangays doing the spatio-temporal analysis. This supports the move to focus on locking down selected granular areas rather than the entire province or highly urbanized city or independent component city, which heavily impacts our economy. And lastly, disease model projections show that lower cases can be achieved when we improve on our minimum public health standards, case detection to isolation time, and vaccine coverage even at lower community quarantine classifications. This highlights the importance of active case finding, intensive contact tracing and testing, early isolation of infected individuals, and enforcement of minimum public health standards, plus vaccinations. So now we go to our alert level system. First, let us answer the question of what is an alert level. Alert levels were designed to be a guide on what needs to be done given the current COVID-19 situation in an area. Each alert level is accompanied by a set of interventions to focus on across the different component strategies of the national COVID-19 response. Given this, it is an action-focused approach to classifying areas. An alert level is not equal to the community quarantine classification. The current community classification framework focuses on healthcare utilization to escalate, whereas alert levels look into both case data and the COVID-19 beds utilization to classify areas. Furthermore, this alert level classification can be a basis for establishing a feedback loop to ensure that actions are done to address any worsening in the COVID-19 situation in the area. Unlike the previous framework for community quarantine classifications, where escalations are solely based from the healthcare utilization rate, the alert level consider both case classification and utilization rates. And this is a more encompassing view of the COVID-19 situation in an area. Using these metrics, we can delineate increases in utilization that is driven by increase in cases and will be the basis for classification to higher alert levels. This is a visual presentation of the alert level system. In this framework, it is shown that alert level classifications consider both case transmission and bed utilization in its classification of areas under alert levels 1 to 5. Using this criteria, the National Capital Region will be under alert level 4, given the following metrics. In terms of case classification, the National Capital Region is at high risk given a moderate risk 2-week growth rate at 28% and a high risk average daily attack rate at 39 per 100,000 cases or population. On its health capacity, total bed utilization of NCR is at moderate risk at 69.58%. However, ICU utilization is currently at 77.58%. We shall be regularly assessing the situation in the National Capital Region to monitor the changes in cases and utilization data, as well as the implementation of the recommended strategies and activities aimed at reduction of case transmission and hospital utilization during this Uulitin ko rin talaga. Sige. Using this criteria, the National Capital Region will be under level. Using this criteria, the National Capital Region will be under alert level 4, given the following metrics. In terms of case classification, the NCR is at high risk given a moderate risk 2-week growth. In terms of case classification, the NCR is at high risk given a moderate risk 2-week growth rate at 28% and a high risk average daily attack rate of 39 per 100,000 population. On its health capacity, the total bed utilization of NCR is at moderate risk at 69.58%. However, ICU utilization is currently at 77.58%. We shall be regularly assessing the situation in the National Capital Region to monitor changes in cases and utilization data, as well as the implementation of the recommended strategies and activities aimed at reduction of case transmission and hospital utilization during this policy shift pilot implementation. In this slide, we summarize the action points per alert level. Here, we focused on 8 response components, and we tried to indicate here the difference in approach for each component per alert level. However, it must be noted that while there are certain differences, some of the interventions remain constant in each intervention. In particular, we note the components that more or less stay the same per alert level, while others have more specific instructions per alert level. First is case detection. This is crucial in all levels. We simply emphasize that in areas with increasing cases and bed utilization, This must be further intensified to ensure that cases are found and managed. Whole genome sequencing. Alert levels 1 and 2 would focus on securing samples for representatives in the area. In alert levels 3 to 5, samples will be taken from priority areas, meaning areas with unusual spikes and identified clusters. This is to see if a known or new vaccine of concern is driving the increase in the number of cases. Third is risk-based testing using Rtpcr. It shall be implemented across all alert levels. However, we may use antigen test in alert level 3 and up to facilitate faster detection of cases among the symptomatics and the close contacts. Fourth is contact tracing. It should prioritize location, assessment, and the quarantining of close contacts. Next is isolation, which is to be done regardless of alert levels. Facility isolation is still encouraged. The next would be on triage and referral up to treatment. The presence of a good triage and referral system and adequate beds and healthcare human resources lowers our healthcare facility utilization rate and ensures that severe and critical cases which require admission are prioritized. In the higher alert levels, focus will be on addressing increasing healthcare and critical care capacity to accommodate increasing admissions. And lastly, vaccination. It shall be fast-tracked with our A1, A2, and A3 populations at most priority as they have the highest risks for severe disease and fatality. For areas in alert levels 3 to 5, vaccine deployment will be reprioritized to areas with increase in the number of cases. For Alert 5, approach is almost similar to Alert Level 4, but guidelines applicable to ECQ shall be observed. Overall, as the alert level increases, there will be an increasing focus and intensity in the interventions to be implemented. The alert levels 1, 2, 3, 4, and 5 would not be the same as the previous community quarantine restrictions since it also considers the 3 C's framework: close, crowded, and close contact in allowing certain activities. The country is moving towards more targeted and recalibrated actions towards high-risk activities, imposing these localized or granular lockdowns at the household and barangay levels and implementing targeted response strategies to prevent transmission and eventually reduce economic strain. Alongside the shift in this policy, we must continue to religiously and correctly adhere to the minimum public health standards and ramp up our vaccination and prioritize the most vulnerable and high-risk population groups. Maraming salamat.